Okay. Okay. Hello, my name is Larry Dawson. I'm the President and Chief Executive Officer of the Illinois Association of Community Action Agencies, and I'm overjoyed to present this expert panel to talk about a very timely issue with regard to vaccine outreach and access. And we have a great panel for this discussion, and I'd like to go ahead and get started introducing them. First, and I'll introduce them alphabetically. First, we have Dr. Ojichika Alozie, who is a graduate of the University of Minnesota's Infectious Diseases Fellowship. Dr. Alozie received his medical degree from the University of Benin in Nigeria, and then completed his internship and residency at the Hennepin County Medical Center in Minneapolis, Minnesota, where he got his introduction to digital health. He is also board certified in clinical informatics by the American Board of Preventive Medicine, making him one of less than 100 such certified physicians in the state of Texas. Next, we have Derek P. Lindblom, who currently works for the mass vaccination and mobile vaccination for the state of Illinois. He started his career on the United States Senate Judiciary Committee, where he was a key advisor to Senator Charles Schumer and led the drafting of groundbreaking and identity theft legislation endorsed by the New York Times and Seattle Times editorial boards. Derek wrote bills and organized coalitions on comprehensive gun safety, civil rights, equal pay, choice, and women's rights, among other issues. He also joined Rahm Emanuel's administration as chief of staff of the mayor's economic council, where he was a senior policy advisor. Dr. Ian Moore is an investigative veterinary pathologist and section chief for the Infectious Disease Pathogenesis Section, IDPS. The IDPS serves as a central research pathology core laboratory within the National Institutes of Health, the National Institute of Allergy and Infectious Diseases. Dr. Moore was invited to be part of the NIH's research team that would take on the task of developing and assessing an mRNA vaccine in collaboration with Moderna. And thank you, Dr. Moore. That's actually the vaccine that I took myself. Dr. Amal Tokars serves as the assistant director at the Illinois Department of Public Health. She has a master's of science in the area of systems therapies in the clinical setting. Her doctoral work emphasized her love of organizational learning, social movement, and research methods, as well as a cognate in anthropology. Her graduate and doctoral work was completed at Northern Illinois University in Illinois. She's also a graduate of the Navy Postgraduate School Executive Leaders Program in California. These are our panelists, and I will turn it over to you. Dr. Alozie, I think you need to unmute yourself. Let's see.
It's always the joy of technology, isn't it? Just when you think you've mastered it, through a pandemic that has pushed us online more than anything else has in our lifetime, it continues to fail. I take extra umbrage at myself internally because in a former life, I was a chief health informatics officer for 8 years. So you'd think I'd have this technology thing down, but it can fail anybody. I will apologize if my signal glitches in and out a little bit. I'm actually down in Curacao doing some COVID work for them here. They had the worst surge in the world prior to India. And so working with the DoD contractor. And so sometimes the internet gets a little bit glitchy. I'd like to sort of start, and we can take this a host of directions, but I think myself and Dr. Moore have historically sort of run through a presentation. We're not going to do that today. I think what's more important is sort of bring people into the conversation. I will tee up a few things in terms of where are we right now and where did the group think we're going to go. and then we'll just open it up to a host of questions around there. I think what's exciting and important as a group is that everybody knows what COVID is by now. We wouldn't be here if we didn't. This is a timeline of some highlights of things that happened throughout 2020. And whether it was the identification that SARS-CoV-2 could affect multiple organ systems, whether it was remdesivir, hydroxychloroquine, dexamethasone, or the miraculous and amazing science that Dr. Moore and his team and others in the pharmaceutical arena drove, you can see that we had an amazing year in terms of science. What's exciting and what has made our conversation today possible is that we really have this conversation. This has been the year of the vaccine. How do we now go from the hard task of creating this vaccine, which really proved to be quote unquote easy, to what should have been the easy task of vaccinating our communities that has proven to be immensely hard? And so I'll stop there and open it up to the panelists individually to sort of comment on that before we go forward.
Well, I'll just take the lead on that. You know, this is a very interesting time for us. We're in a situation where we now have 3 vaccines that are have authorization by the FDA. And at this point now, we're in a situation where people have to make a choice, and that choice needs to be based on accurate information, needs to be based on facts. And being a resident, or not even a resident, I live in Maryland, but I grew up in Alabama, so I'm from a rural area. And so that was a driving force for me to communicate with people. I knew there were going to be some questions. I knew there were going to be some areas of hesitancy. Although hesitancy doesn't paint the entire picture of a number of categories of people across the country. But I think just truth and corrections of misinformation are going to be key to, you know, the discussions today, and key to people getting vaccinated moving forward. So, you know, hopefully everybody can pull something from this information and make the right choice for themselves.
Absolutely. I appreciate that. Amal, what are your thoughts? We can't hear you.
Still no sound.
While we're trying to get through that technical difficulty, Derek, what are your thoughts on this?
Sure. So first of all, thank you for having me, and thank you for doing this. I think this conversation is, you know, an incredibly important conversation to have as we move to, I think, what you very well identified, Doctor, as the most challenging phase of this, which is trying to figure out, you know, how do we have that one-on-one conversation with millions of people where we tell them about just what a miracle and just how effective the vaccine is. You know, I've spent a lot of my career in healthcare technology and, you know a little bit about, vaccines, nothing compared to some of the medical professionals in this panel, but know a lot about how delivering healthcare and how do you get out to folks and how do you give folks healthcare information. And I think, you know, a lot of us in that field were concerned about this part of the rollout because we knew it's a challenge when lies get spread out there, when folks get misinformation and, you know, spread that misinformation to as many people as they can through new social media channels and others. And the most important thing for us to do is figure out how do we deliver that message, not just, you know, to one person or 2 people, but have those important conversations at scale to let people know that, you know, this is frankly one of the greatest medical advances in the history of the country. This is unbelievably effective. And I think the doctors on this panel could talk to this much more effectively than I could. But if we had known just how effective these vaccines would have been a year ago, I think everyone would have been flabbergasted. And it's really just, you know, getting the truth out there as fast as possible. You know, I had a boss once a while ago who said the key to this operation we were trying to do was to tell the truth faster than others could lie. And I think that's really what this is about, is getting the truth out there faster than the people who are spreading rumors and spreading misinformation, and convincing folks, including some communities that have, you know, justifiable reasons for being skeptical of new medical technology, just how wonderful this is for everyone involved. And I think that's the challenge before us. And I know there's a ton of people, both at the state of Illinois, like Dr. Tokars and others who are leading that effort, and then around the country and around the world who are trying to make that happen.
Excellent, excellent. So, do we have some of those technical difficulties rectified? Can you hear us? Can we hear you? Maybe not. Yeah, I think we're still having some technical difficulties. And so while we try to work through some of those technical difficulties, I'm going to tee up some other information into the group, and hopefully that'll elicit some more of this conversation. So as I open this up here, just let me know when you can see my screen. Can you see my screen?
Not yet.
Now, apparently, it's my turn to have some technical difficulties. Trying to ensure
we just have to get them all out the way early.
I love it.
All right.
Out the way early.
Yeah, that's the best thing. All right, I got this. I thought it was going to get shared for me, but I know how to share. All right, cool.
There you go.
I think as we sort of talk about that conversation, and I mean, I think you pivoted really nicely to it, both of you, and you talked about we need to figure out how to let the truth beat the lies, how to let the science beat the fiction. And I think it's important to understand where we are in the United States around this vaccine distribution. And so if we really look, and I love this Connor Kelly GitHub graphic that he sort of put together, you can see that we've distributed 312 million vaccines and administered approximately 246 million. Excellent work. The unfortunate thing is that if you follow this work over the course of the year, you can see that we hit our peak on April 10th, and we administered almost 5 million vaccines that day with a high 7-day average of 3.11 million. Unfortunately, since then, it's consistently gone down. Even more sort of disheartening, and you probably could have done the math better than I can because my math is not my greatest strong suit. But if this GitHub reloads, you'll see that we have approximately 67 million vaccines that are sitting out there, quote unquote, on shelves. And so when we talk about how are we going to win this arms race, what are your thoughts? And I will reverse the order of this, and I'll ask you to go first, Derek, and then potentially we'll shift over to Chicago and see if we have that working.
Sure. And I think, we always knew there was going to be a curve. That curve was always going to look like it did, because you're going to get to a point where, the bulk of the channels, what's moving the fastest, the folks who are, if you look at the information, who are like, yep, sign me up right away. And then there's some group of the population that says, whoa, I'm never going to get a vaccine, whether for ideological reasons or some other reason. But there's a significant group of the population here, that I refer to as the maybes, that if the vaccine is given in the right context, in the right ease of use, and with the right trusted verifiers validating that this is a safe and good thing to do, we can flip those folks from maybes to yeses and get a vaccine in their arms. And I think that conversation is not, it's not a one-person conversation. There's no magic bullet, but it involves both logistics and making the vaccine available in a way that's convenient and accessible to them. And it also involves a conversation of trust, a conversation of getting to folks, not with the government or someone top down telling them, but whatever person or resource they trust, whatever they, comes to them and they believe in, getting that voice in their ear at the right time. And if you kind of combine the logistics aspect and the trust aspect, I think that's how you succeed with, getting our maybes into yeses. And then the hope is over time, with more education, with more kind of slow work, you can turn some of those no's into maybes into yeses.
Excellent. Excellent. Dr. Tokars, we're going to go back to you again and see if our technology will hold up.
I'm hoping that you can hear me
yes.
now.
There we go.
Okay.
Success.
You did a great job. So here's what I really am excited to say to you. We know that in this country, when the supply is little, the demand is great. And we knew that when the demand, that when the supply went up,
Oh, we lost her.
Uh-oh. We lost you again.
is
Oh, there we go.
what this tells us is how important important it is to think about vulnerable populations and how when each of us gets vaccinated, it really helps us pay it forward to others. So for example, we know that our elders were the most likely to pass on and lose their lives, not only in Illinois, not only in this nation, but all over the world. Elders were the most likely to lose their lives. In Illinois specifically, when we look at elder death by race, we saw that elders who were Latino were very likely to pass on in their 60s, and elders who were Black were very likely to pass on in their 70s, which is one of the reasons that we wanted to, when our federal partners talked about 75 and older last year, we really wanted to go with 65 and older. But those of us who are not elders may feel, well, it's not really very risky for us. We could get sick and then we'll get better. But there is this asymptomatic spread that we cannot forget about. And it impacts not only elders, but all individuals that have many of these comorbidities that we know about. Diabetes, heart disease, lung diseases, even being overweight is one of those very significant comorbidities. So for every single one of us, even if we don't have those comorbidities, it's so important that we pay it forward. Children cannot yet get vaccinated at this time. They can if they're 16 and 17, and we're looking forward to some younger children being able to get vaccinated in the future, but the little ones cannot get vaccinated. So every adult who is eligible, which is every adult, needs to really think seriously about standing up and standing forward. And so those intelligent, wonderful questions that people have, those worrisome questions, ask them and let them be answered. Ask your friends and people that you know and trust what normal side effects they had and how they're feeling now. Ask them and let those questions get answered. And then find your way to getting that vaccine. I also had to wait along with the rest of you to be vaccinated, and I just recently was vaccinated. And if people ask me, I'm happy to tell them what side effects I experienced, the normal side effects, and then I felt better. And I'm so grateful to have these high efficacy vaccines among us. Also, one of our community action leaders had asked me to address another piece. As we know that death is stabilizing, but there's still people dying every day, and our cases are going down, and our hospitalization rates are stabilizing, it could seem like, well, we don't really need to worry about the vaccine anymore. This is still our time. Even when we are out of the pandemic, it will be so critical that we get vaccinated. So please take this opportunity, this gift of science, and let's not take it for granted. And let's make sure that we close the loop on these disparities that have been very real and still are real around the world. I spoke a long time. I want to make sure my mic doesn't go out, so thank you.
Thank you immensely. And so I will go over to Dr. Moore now. Dr. Moore, what are your thoughts?
Everybody has made really, really good points. And I mean, it just goes back to communication. I think that has been the key obstacle for everybody right now. I mean, from a government standpoint, from a local standpoint, people have questions about how these vaccines work, how effective they are, were they made too fast? These are all some of the common questions that we come across. And I have, I've spent, as well as for the last 6 months, I've been talking to people on the ground, small groups, large groups. Is my mic okay?
Yes.
Okay. Small groups and large groups, just trying to get information out to them. You talk about mRNA to a person who to a scientist, yeah, that's fairly common. In the medical profession, it's fairly common for you to talk about mRNA or DNA. But then you try to take that to people who don't deal with it on a daily basis, and they know it's a newer technology. So now they want to know how to make me feel comfortable about it. And so then I feel, I mean, probably in 80% of the cases that I've talked to people, if I've had the time to speak with them directly, they understand it, and they understand that some, as Dr. Maul mentioned, the side effects. Side effects are not a bad thing. Mild side effects are a normal thing. That means your immune system is responding to a vaccine, which it should. And so these are all key areas that I think the things are mentioned, but they're not explained. And I think that's where we need to take more time in explaining. And I hope that we do it in this conversation. You know, I took the Moderna vaccine. You know, unfortunately, because I am a scientist, I was sitting there watching myself I was watching myself for 24 hours, and I said, here it is, here it comes. And then 24 hours, I started feeling a little achy, a little sore. You know, but then 24 hours later, I'm up, running around. I didn't feel like anything had happened. And that's kind of the whole point. I would dare say that most of the medications that people take, and if you watch any of the commercials on TV, they have a lot more side effects than a sore arm, you know, a low-grade fever. We're talking about diarrhea, and, you know, sometimes, I mean, for those people who care about it, erectile dysfunction, all these things are side effects of very common drugs that we take. And, you know, but people are picking and choosing what things they want to deal with. But ultimately, it comes down to what's most important, and your potential to be infected by a virus that we know is killing, at this point now, 577,000 people in the country.
Absolutely. Truly appreciate that insight. I'm going to take a break now to answer one of the questions that's on the screen. It's from Odette Hyatt Watson. And it says, one of the concerns I've heard from many is the quick discovery of these vaccines. What can we say to address the concerns that the vaccines were developed in a remarkable amount of time? Was the development time of the COVID vaccines a typical amount of time to develop a vaccine? So it's kind of myself and Dr. Moore have done this a host of times. So this is sort of a Jordan to Pippen alley-oop to you, Dr. Moore. I mean, your lab was a part of the process that got this kicked off.
Right. And that's a good question. That is a fair question. You know, the way I like to explain it, you know, so first and foremost, these technologies, and I kind of hate to call them technologies because it makes it sound like some science fiction. So the method of vaccination using mRNA, it's actually been around for almost 2 decades. It's just that we have never had to use it in this capacity because we've in our lifetime, we've never experienced a pandemic. And so in the traditional sense, if you make a vaccine, let's say for influenza, that's actually my background. I was an influenza researcher, as a PhD student. And if you can imagine, you have to grow virus up and enough to make vaccine doses. But can you imagine growing virus up for 300 million Americans? So what happens is, I like to use the analogy of building a house. And this is going to directly translate into the vaccine process. You move into a neighborhood, you want to build a house. Now, how long would it take you to build a house if you had to buy all the supplies yourself? You had to build, you had one hammer and a box of nails, and they say go to work. How many years would it take for that house to be built for you to completely be able to live in it worry-free? Now, same scenario, you go to a neighborhood, you want to move in, same plot of land. Now your neighbors come out and they say, hey, you know what? We want you to live here. We're going to pay for that. We're going to pay for your house to be built. We're going to help you build it. How much quicker does that house get built? The house, it goes from 5 years to now maybe a couple of months, depending on the people. And so that's the same thing with the vaccine process. We have a number of phases. We have preclinical, which is the phase I was involved in. You have phase 1, phase 2, and phase 3. And then you have a review period. Then you go to FDA. All those periods, phase preclinical all the way to phase 3, they usually take a long time because they have a lot of money involved, a lot of time involved in between. But if you can imagine a pandemic, when there is nothing else to do but focus on this, and the money is paid upfront for these phases to be taken to task. If that's the case, imagine how much more condensed that process can happen in. And so that's why people say, was it done too fast? The same process was done. It's just you remove the need for money and and some things can be run in parallel. So the same time and same scrutiny was placed on this vaccine as any other. It's just that we had no other thing to focus on but this, because there's nothing more important than this right now. So that's just my little spiel on, on how this vaccine was developed so quickly, but still very, very efficiently, and the safety and efficacy speak for themselves.
Excellent. Thank you very much. I'm going to tee a topic up, then I'm going to come to Derek. So I'm going to share my screen again, and then we'll go from there. So we can put up my screen in 3, 2, there we go. So one of the conversations that has been out there since the beginning of this pandemic and even up till now is this concept of herd immunity. And I know a lot of people have gotten bogged down with, is it 50%? Is it 60%? Is it 80%? I know Dr. Fauci at one time last year and early this year said even up to 90%. And I feel as if we get caught up in that. I think it's important from a science standpoint to remember in the countries where we have the best data, the United Kingdom and Israel, they started to see effect, which is a precipitous drop off in cases and hospitalizations when they hit around 40% of both doses and about 55 to 60% of one dose. I shared this figure from the Kaiser Foundation, which shows the percentages and the states. And you can see that from the top right, we have Massachusetts, Vermont, Rhode Island. And down in the bottom left, we have Mississippi, Louisiana, Alabama, Georgia, Wyoming. And so it's going to be really important for us to message this properly. And this is where I'm going to come to you in a second, Derek. And so this is an example of the St. Louis Post-Dispatch recently. Vaccinated person test positive, 71 cases. What they forgot to mention is that this was less than 1% of the total cases that had been vaccinated. There's actually almost 23,000 cases that had been vaccinated. I think it's important for us to remember that whether it's nursing home residents, CDC frontline workers, Mayo Clinic workers, Rockefeller University employees, which were all active surveillance, nobody had symptoms, nobody was sick, consistently the infection rate of people that have been fully vaccinated is less than 1%. If we take the CDC data and see how many were symptomatic, hospitalized, and unfortunately died, you can again see those percentages are amazingly low. If Dr. Moore and his group had thought it would be that low back in the day, or that amazing back in the day, like you said earlier, Derek, we would have led with this amazing amount of information. And so I'm going to pause there and swing it back over to you, Derek, and say, what are your thoughts?
Yeah, I mean, I think you said it probably better than I could, which is it's just, when so much of what we do is less, hey, here's the data, and more helping people interpret the data in a cacophony of, sound and anger and crazy things that go out there on the internet and everything, and help them understand exactly what we're seeing. And the fact is, every scientist will tell you no vaccine is 100%. But these vaccines are basically as darn close as you're going to get. And that's what's so exciting about them. And, Dr. Moore and his team and others who work to develop these vaccines, they're miracles. Like I just try to tell everyone, when we talk to them, these are a gift from God. These are amazing. And when we look at this and what these vaccines can do, I think when you've seen what, quote unquote, breakthrough infections, you've seen an incredibly low rate. And then the wonderful part is where you have seen those infections, even in extremely vulnerable populations. There was a nursing home study out of Kentucky, and even with the worst variants so far, we're looking at still a huge amount of protection from hospitalization and especially from death. I mean, it's just incredible how well the vaccines have functioned. And I think getting across that message of, look, nothing's perfect, but in this world, there are very few things that are better than these effective COVID vaccines. But I think, the headline that you brought up is something that personally drives me nuts, which is, we have some great newspaper reporters and other reporters here in the state of Illinois who've done some very thoughtful reporting around this and around breakthrough infections and around just what it is. And they put it in a context folks get. But then there's also folks, in the St. Louis Post-Dispatch and others who don't understand and don't try to understand the science. And you get headlines like a vaccinated person was infected. Yeah, that happens once in a while. And you know what? They probably had a mild or asymptomatic infection when they could have previously been going to the hospital or even dying. So it's one of those things where we just got to keep telling the wonderful news about this. And, you know, I always joke, I love any graph that you put up that shows Illinois ahead of the pack when it comes to vaccinations. We're very proud of the efforts we've done. A lot of late nights, a lot of folks on Dr. Tokar's team and others who have a lot of bleary eyes from working so hard to get it out there. But I think we all know our work isn't done. And in fact, the hard part is kind of just beginning. We had some real logistical challenges at first getting it out there. That was what every state in the country was facing. And, you know, I'm very proud to say Illinois succeeded with flying colors there. But now we have this challenge of how do you get it to people individually? How do you convince every person that, yes, this is important? And you know what? The things you brought up today, the very thoughtful reasons people might object, we can have those one-on-one conversations Dr. Tokar spoke about with, and, you know, really help them understand that this is a great choice for them and their family's health. But look, you know, we're in a situation here where we're all shifting. We're all making that pivot to that convenient, you know, from mass vaccination to convenience vaccination, from vaccinating as many people as we can in a day to making sure we get to everyone we can over time. And those are very different, you know, I guess, plans, but they're plans that I know the governor and Dr. IACAA and the whole team here at the state of Illinois have been ready for and excited for, and it's taking it to the next phase.
Excellent. I truly appreciate the way you sort of broke that down. Dr. Tokars, I'm going to pivot to you in a second. I'm going to show a graphic and then swing back. But before we do that, Dr. Moore, there's a question from a Mr. Harold Rice, and he says, Ian, as it relates to myths, can you speak on the Tuskegee experiment as it relates to concerns around the vaccines?
Absolutely. And so for those who don't know, actually, my undergrad time was spent at Tuskegee as well. So I was baptized in this myth of what it means to be Black and associated with medical research. And so I want to speak to something in particular. I have never heard Tuskegee's name mentioned so many times, and it's a small school, and it's a small historic school, and I have a lot of pride in my institution. Before this, I would say Tuskegee Airmen were the primary thing that were mentioned when in reference to Tuskegee or the vet school, because we have a veterinary school, or just some Booker T. Washington related fact. Now it's situations where people always mention, well, you know what happened at Tuskegee. A lot of times people say that and they don't know what happened at Tuskegee. And actually, if you speak to people who are in Tuskegee, who live there, the actual residents of Tuskegee, who are some of them direct descendants of people who were associated with some of these studies, they actually take somewhat of an offense to people calling it the Tuskegee experiment. It's actually referred to the United States Public Health Service study of untreated syphilis in the African American male. In particular, that's a point that I want to make. A lot of people say, well, you know, they were infected with syphilis, and that's actually a big myth that is perpetuated. And so now you have people in the African American community and others who are assuming that the Tuskegee syphilis study, or the study of syphilis, untreated syphilis in these men, were given to them, and that's not factual. They had syphilis, and that syphilis was untreated. And during the course of the study, which was from 1930 to 1970, around the 1940s, antibiotics, which was the treatment of choice, was available. They just didn't give it to them. So we need to clear up some of those things, because if you understand the history of what happens, you can also understand how to interpret things moving forward. So that was one point. But I want people to know that this is, first and foremost, this is not the 1930s. And those things, while they were a very ugly scar on the history of our country, they're not the truth of today. They're not the reality of today. We're not being experimented upon by these vaccines. That's where our clinical trials are for, and that's what our preclinical studies are for. We get that stuff out of the way first. And so when you get a vaccine, you're getting a safe and effective vaccine that has been, and to Derek's point, he is right on the money when it comes to it. The hope was that these vaccines would be 50-60% effective, best case scenario. Some of the vaccines we have right now for flu, for influenza, 56% efficacious. That's great. And that's actually the threshold for FDA approval. Now you have, when it comes out, 94, 95, blows the roof off. I remember when I sat down and looked at some of these slides for the very first time, and when I looked at them, I promise you, I checked these slides probably 70 times. I'm talking about hundreds of slides. I went back over and over again because I could not believe how effective this was. But then once it went through clinical trials and once everything came out, I wasn't surprised. I just wanted to make sure I wasn't making a mistake because this was working so great. So 94, 95 is the truth. And another number that Derek mentioned, or that you guys were talking about, was the amount of breakthrough cases, the very low incidence. I heard a number today. Out of 95 million vaccines from Pfizer and Moderna together, there were approximately 9,000 cases of mild symptomatic disease. That comes out to be 0.009%, or you can interpret that as saying these vaccines are 99.001% effective and protective. That is amazing. That is amazing. And so when you have those choices and people are still trying to make a decision, the decision is pretty easy if you put getting sick versus protecting yourself with almost 100% protection. So I'll leave it at that.
Absolutely. I appreciate it, Dr. Moore. And so, Dr. Tokars, I'm going to tee you up, but in doing that, I'm going to sort of pivot a little bit to how do we expand this conversation? How do we make it different? How do we get to those groups that don't historically have wanted to get vaccine? And this is a graphic from Just Healthcare that I took off the internet the other day, and it really talks about the vaccine status of the United States. And you can see coming from December where the definitely not percentage has consistently stayed the same. What has changed is that wait and see has gotten smaller. As soon as possible, spiked when it was available, then has gone down to about 30%. And obviously, we have the vaccinated portion. But if you really look at how do we target it, and I think your group in Illinois has done a really great job of this, what are those patterns of these vaccine hesitant populations? I think the word vaccine resistant needs to be put in the trash. Nobody's necessarily resistant, because the question I have to those that talk about resistance is, have you created mobile vans? Have you given them PTO? Have you given them incentives? Have you made it as easy for people that don't have broadband and internet and a host of other things to access vaccines? And so whether it's the watchful, the cost or time anxious, the people that just don't trust the system, or the misinformation believers, which are probably the hardest to get to, Dr. Tokars, what's your thought about how your organization, the state of Illinois, can get to these watchful and cost and time anxious?
So first of and I think this is vaccine matters of vaccine confidence. So I don't want to speak in a deficit discourse about the individuals that we are thinking about, because vaccine confidence is not only about individuals that are worried about the development of vaccine or they're worried about the side effects, but it's also individuals that have very hard lives and chaotic lives sometimes and have a hard time making this a priority when they're trying to maybe work 2 jobs, pay attention to how the children are doing in school. There are safety issues maybe in the neighborhood. So vaccine confidence is a very broad issue. And therefore, to understand the individuals that we are thinking about, we have to understand that they are very diverse. And their reasons for not yet getting vaccinated are also very diverse. And we want to really be able to hear all those reasons and help very, very specifically. So let's take an example of our healthcare workers. People in the healthcare field who were eligible very early, and many of them took it, and many did not yet take the vaccine. So we have to understand, why is that? Why is that? So there are many reasons. If an individual traditionally has not taken their flu vaccine, some are motivated to take the COVID vaccine because they do understand that it is much more serious. But there are those that still will wait. And so we have to also have conversations with our brothers and sisters in the healthcare community about, if we are near others and our choices have an impact on others, it's really important that we are taking the vaccine. So there is one example. Now, we are speaking with a marvelous community action audience. And our community action workers, what are they doing? What is their work? It's very diverse work. They are helping individuals who need energy assistance. They are processing applications. And many times they are sitting down and hearing about many other needs that those individuals have in their lives: food needs, mental health needs, mortgage issues, worries about being homelessness. This takes time, this takes attention, and many times individuals, even though in COVID, many of them, I imagine that many of our colleagues are meeting in person with individuals now, and those persons are vulnerable. So it's really important that our colleagues are paying attention to the impact that they have on those individuals in terms of their own immunity. We are weatherizing homes, means we're in people's homes who have been in very difficult circumstances. And that is a very intimate thing, being in someone's home. So are we paying attention to our immunity and what impact our immunity has on those we serve? Many of our community action agencies are providing WIC services. We're holding babies, measuring babies. So we really need to be paying attention again. So the work that we do is intimate work in many ways. And if we're helping others, we have to think about every way that we impact others. So I'm giving you examples of ways that we need to talk about. There is not a generalization that we can give to motivate people to do the right thing for others. We really have to think about what are the specific circumstances we're in, what are the specific concerns that people have about the vaccine. And sometimes we have to answer those questions in small groups. Right now, we're in a large group. Not everybody wants to ask those questions in a large group. We have to be willing to hear people in a small group and let them ask the question in many ways. Sometimes the same question, I notice, in small groups will be asked 3 different ways when it's essentially the same question, and then we should answer it 3 different times and do whatever it takes to help those individuals. So that's part of my answer. The rest of it would take a very long time, but we have to understand that these are that are concerned about the vaccine, and we need to answer all the questions, and we have to get at those very specific needs that people have.
Excellent. Thank you so much. I appreciate that in-depth answer. I'm going to pivot to another question that we have, and it's from a McFarland Bragg II. My daughter's a second-year medical student at Meharry, currently doing a rotation at Good Samaritan Hospital in Cincinnati. She said, show photos of an individual's lungs suffering from COVID and it will shock people. I think she's right, right? I can tell you from a clinical standpoint, whether it's in the United States, whether it's in Navajo Nation where I've worked, in El Paso, Texas, and now in Curacao, nobody needs to be told twice, whether it's in the emergency room, the ICU, or the general floor. Once we pull up that x-ray or once we pull up that CT scan, everybody knows what it looks like. It's essentially all of the lung disappearing into inflammation and fibrosis. And imagine if those old school sponges that people used to have, those fluffy yellow sponges, and then you get it wet and leave it outside for a day or two and it's rock hard. That is what somebody's lung becomes with COVID disease, COVID pneumonia. It can't move, it can't squeeze, you can't get air in or out, and they are literally dying and suffocating. You've seen the tragic images that are all across our news now because of the tragedy that's happening in India. And so again, I don't think that anybody that, and again, I'm overstating. I gotta remind myself not to generalize, but it's rare that the average person, when they've been either affected by the death of SARS-CoV-2, COVID-19 disease, or seen somebody struggle for life potentially, either on FaceTime, since most people couldn't be in a hospital with them and their loved ones. If you have that touch you specifically, you find out very quickly that people pivot their ideas. There was actually a New York Times poll that came out, I think, Q4 of last year, right before the vaccines were available. And it showed that the likelihood of somebody to want the vaccine, this was pre-vaccine, was directly related to number one, what was the spread in their area? What was the case per 100,000? And number two, did they have a first or second degree relative that had already had COVID? If either of those things were high, their likelihood to receive vaccine was high. And so, unfortunately, in our country, because of politicization, because of the entrenchment in various camps that has existed on I'm a masker or a non-masker, I'm a vacciner or a non-vacciner. Those have become our tribes. And as human beings, we're very aligned with our tribes. I want to be like my tribes people, and we forget about the rest of it. And so, but hey, good luck to your daughter. I'm glad she's doing a rotation. Good Sam is a great hospital, and she's at a great institution in Meharry. I'm going to flip to another question that is up there. I can see it, but if you can put it on the screen, that would be great. It's from Harold Rice again, and it says, Amal and Derek, on a local level, can you speak on the mobilizing efforts of the state with community action agencies in mitigating access for vaccinations for hard-to-reach communities, as well as educational support? I'll turn that over to you first, Derek, and then we'll go back to Dr. Tokars.
Actually, if you don't mind, well, can we do the reverse? I think Dr. Tokars, and
Okay.
I've heard her do this before, speaks very well to kind of the high level strategy. And then I'll do the less exciting part, but talk through some of the logistics involved and, how we do, the nuts and bolts that is my end of the world.
Absolutely. You're a gentleman. I didn't want to overstretch Dr. Tokars since she had just talked, but Dr. Tokars, back to you.
Actually, Derek has the more exciting part, but so there are these 5 ways, and Mr. Rice has heard me speak about this before, that we are thinking about our vulnerable communities and how important it is to engage. So one of those is that in Illinois, local health departments are separate agencies. They're local agencies. They're separate from the state. And it's very important that they have vaccine and that they are partnering with other agencies, letting them know how the people they serve, that's what that means, partnering, letting them know how the people they serve can get to that vaccine. However, it's also very important that those agencies, because the health department works with many agencies, may not know all of them, that if there are specific areas of difficulty that they want to ask or strategize about, that they really also are working with their local health department. So that's the first part of that strategy. Another one is a community ambassadors initiative that we have started. These are non-healthcare, non-public health persons. They are very diverse in race and ethnicity, and they are in every county in Illinois. These are people that want to be in the know and share what they know very informally. And so we push out information to them. They may reshape that information, put it out. If it's something that's technical, we give it to them in a PDF because we don't want that to be reshaped. But otherwise, we want them to share what they know about where to get vaccine. We want them to share what they know about antibody therapy. We want them to share what they know about testing and testing accessibility, and about vaccine and the worthiness of it, and the quality of our lives that we can really sustain and take back through these tools which are very, very important to us. So the Ambassadors Initiative is very, very important. A third area is outreach to community groups. There are many community groups that we are working with, many faith-based organizations, union groups, many other kinds of organizations that we are reaching out to, but also have reached out to us to ask us to tell them more. Much of this now, you can imagine, is about vaccine confidence. In the beginning, it was about vaccine access. Now it often relates to vaccine confidence. Sometimes those are large meetings. Sometimes those are modest-sized groups, because sometimes that's just what it takes to help get at that. Another area is really looking at the digital divide. Providers have needed, especially in the beginning, to have appointments that were electronic just so they could manage this whole challenging affair. But we have also encouraged providers, and many providers have been taking telephone appointments. We have started a hotline some time ago. This is for people that feel that they're not confident or with their cell phone, or they don't have a cell phone, or they don't have a computer. Then they can call us And if you don't have that phone number, we can get that to you after this meeting, and we will make the appointment for those individuals. There are many sites now that are also taking walk-ups that welcome family and friends to come together serendipitously to get their vaccine. These are all things that address the digital divide, but also build vaccine confidence. And then finally, the piece that Derek's going to talk about is some of the mobile activities that relate to mobile vaccine. Know that these resources are not unlimited, but they are wonderful resources. And I'll let my good colleague Derek, who is very articulate in this piece, speak a little bit about that to you.
Thanks, Amal. And I think this gets into, what we were talking earlier in the shift from mass vaccination to what I like to call convenience vaccination. And what that is it's, look, every community group, every church doesn't have the resources to have the cold storage chain necessary to do a vaccination clinic on their own. Find a nurse to hire, find someone with the technology to enter it in, put it all together, do it all on themselves. But these institutions are the places people trust. They're both convenient and they're trusted. And I think the question for us was, how do we engage with these institutions in a way that puts their needs first and basically instead of taking it from the state's point of view, takes it from their point of view and says, how do we help you vaccinate your members, the people you serve, your folks? Like, how do we get there and help you succeed at what you want to do? And we've come up with what we call the community partners teams that have been, frankly, stunningly successful. And I like to call it the vaccine clinic in a box. But it's this attitude of, let us take care of all the hard parts, the quote unquote hard parts that we think organizations have said are so hard. We'll take care of all the logistics. We'll get the vaccine there. We'll get it cold stored. We'll get nurses and others to put those vaccines in arms. And we'll make sure we have the technology and everything set up so you can have folks walk in, you can have folks register in advance. And we can do this in your church basement. We can do this, in a community parking lot. We can do this wherever it's easiest for your group to get folks together. And the whole goal is, let us take care of all the logistics. Let us take care of all the clinical parts of it. All we need from community groups is bring the arms, bring the people. You had a slide in the arms race earlier, which I loved. And I think for us, it's just kind of like, we think like that. We think of this as like, how do we get to every day more and more arms? And I think the key, especially now that we've gotten so many folks, there's less folks left who are interested, is to get those community organizations involved. And I got to tell you, the success has been really off the charts because it's been, us not thinking what's easiest for us, but actually thinking what's incredibly hard for us, but what's easiest for the community organizations. Because I got to tell you, if you're trying to deliver a vaccine to a maybe, when it can come from someone, who's from some other part of the state, who's coming in, doesn't know the person at all, has no relationships, and saying, give me your arm, I'm going to stick this in. Or when it's the community group you've worked with for 20 years, when it's your pastor who married you, when it's like a local doctor who, delivered your kid, like that trusted relationship is a very different relationship. So I think we take it, I think we have an attitude of what I like to call servant leadership, which is the idea here is you lead by being a servant. And what we know we're good at is we can get the logistics down so you can basically order a vaccine clinic if you have arms to put it in. And when we know where some other folks have stronger relationships is they have these 20, 30-year relationships built with community groups. And I think what we try to do is provide this vaccine clinic in a box. And frankly, we've had hundreds of requests. And we've been able to fulfill pretty much all of them at this point. So we keep talking about it because the more folks are interested, the more we can do. But we've had stuff like those community partner programs. We've had success making vaccination sites walk-ups, especially in equity-based communities. We've had a lot of success providing resources to the local health departments Amal talked about, whether it's the National Guard or other private sector resources. And then, frankly, a lot of success with folks, who have different challenges, maybe way more rural, and having rural teams kind of go around parts of the state like a traveling circus and really get to different communities that we weren't able to get to, and creating an event-based mentality if someone's there. And I think there's no one-size-fits-all solution, but by bringing together all these solutions and frankly teaming up with folks that have trusted credibility in their communities, we're able to get those maybes and turn them into yeses.
Truly appreciate that. I mean, Derek, that's amazing, right? The vaccine in a box concept is amazing. You talked about arms race, and I see an analogy of the sort of when you're fighting a war, right? You go in with those planes and you bomb first. That's the easy part. That's when the demand was bigger than supply. Anybody that wanted it, they tried to get it hook, line, and sinker, right? Or hook by crook, actually, in some cases. Now, this is a ground war. And the best way to fight a ground war is door to door, person to person. And you hit it right, the nail on the head, whether it's your pastor, your friends, your community organization. Maybe you have a trusted relationship with a federally qualified healthcare system. Maybe you're part of the Navajo Nation. You have a relationship with them. I think what you've done is amazing. And so kudos to you. I'm going to pivot because I see a bunch of questions lining up, and then I'm going to share some figures and go from there. As I share my screen, give me 1 second. It's always fun, this flipping back and forth that I have to do. But as I share my screen, Odette asks a question about Johnson & Johnson, and I will read it specifically, but to paraphrase, it was essentially, what about the media conversation about Johnson & Johnson? Really quickly, you may or may not have heard about cerebral venous sinus thrombosis, one of the side effects or the adverse effects of the Johnson & Johnson vaccine. Full transparency, I received the Johnson & Johnson vaccine for a host of reasons, partially because I unfortunately got COVID back in December of 2020, partially because I was busy and going to Curacao and I couldn't get 2 shots, and partially because philosophically, I like the idea of a one-shot vaccine. And so this data came out, and it was 6 out of 6.8 million people. I think, again, Derek, we sort of talked about that whole press piece, right? It became a clickbait story where everybody said, oh my God, this is what happens in pregnancy. This is what happens in COVID. This is what happens in OCPs. I think it's exciting and was deliberately thoughtful what the CDC and FDA did, which is take a step back and look at it. And I think what people also have to understand is that when you're really looking at risk, it's not 6 out of 6 million, but at the very least, it's 6 out of the women that got it, since at that point in time it was only in females. And then it's, well, what do you expect to happen? Because this was not just what's called a thrombosis, but it was what's called a coagulopathy. Any hematologist or oncologist out there would understand, but it's a very dangerous condition that can actually burn through your body's ability to create clots. And so you can essentially bleed out. And so you can see on the far right that when you look at that 20 to 50, some of those ratios or risk becomes multiple times what we would expect or actually tolerate. And I don't go on the record very often. And I sort of put in my bias up front of the hope that I had for a one-shot vaccine. But I truly do think in the United States, where these kind of risk ratios exist in 20 to 50-year-olds, and Dr. Moore's group, other pharmaceutical companies have created an amazing mRNA vaccine, and the supply now outwhelms the demand, that this is no longer an acceptable option in women in this country as a vaccine process. And so that's just kind of food for thought. One of the other questions that I saw are, what are the long-term effects of COVID-19 disease? And that's a little bit harder. And it's a little bit harder because I can actually say we don't know. We know that 80% of all the deaths in the United States came in people above the age of 65, but we're beginning to tease out some data of this long COVID syndrome or long COVID or long haulers. And what is the lasting impact? There have been reports from across the world, Europe, the United States, a host of other places, of COVID affecting all of these systems that you see, whether it's heart rate. I mean, for at least 2 months, I had a heart rate that was averaging in the low hundreds. It's gone now, remarkably, since I got my vaccine. People that continue to have low oxygen, shortness of breath, kidney issues, musculoskeletal, GI. And so we do not actually know what will happen, the long-term effects of COVID. And I think it's because of that that we actually are telling people, hey, even though you're healthy, we don't know what the long-term effects of COVID are. And so please get vaccinated. I think that's really important. I will open up to a different question. I'll come back to you, Mr. Rice, but there's some other people that haven't been responded to. I got to Andrew Rain's question about long-term side effects. I answered Odette Watson's question about Johnson & Johnson. Donna Henry, she just asked a question, and this is open to whoever would like to answer it. Please share, to your knowledge, the length of time the vaccine is effective. I've heard from medical professionals during educational webinars that it has been proven for approximately 6 months. How often will individuals be required to be vaccinated? Annually? Is this something that should be shared with educating communities? I think we have an expert here, Dr. Moore, on deck.
Yeah, no, that's a fair question, and it's a question that we get all the time. The reality is that, and to be completely honest, Donna, we don't know. We don't know how long the vaccine protects, and the reason we have information out to 6 months is because 6 months is how long it's been since the end of the phase 3 clinical trials. So those people traditionally in a non-pandemic traditional vaccine process, you have people who are in the phase 3 clinical trials and they're watched for 2 years, maybe 3 years further out, and over that time frame, especially for a vaccine, they're checked for their titers, and their titers are checked every 6 months for the next year or 2 years. And so what happens is when those people start to have titers that drop, and potentially if those people ever become infected with that which they were vaccinated against, then that is a point where that's where the statisticians come in and say, hey, based on this titer, based on this incidence of infection, these are the time frames that we need to start looking at. So we recommend that people start getting vaccinated if they have a titer below 8, and if on time point B. So maybe 2 years, every 2 years you get a vaccine or a booster. And so that's information, but because we're in a pandemic, we didn't have the luxury of going out that far right now. So we have to kind of move these two pillars, so to speak, at the same time. We have to move them, slide them down. We check people at 6 months. They still have high titers. Now, we still don't know what the protective titer is, but we know that people still have very high titers. So then we take that and we slide it down another 6 months while we're getting people vaccinated, because we can't wait. If we waited until 2 years and say, hey, now we can start vaccinating people, there would be a lot of other people that would be sick and lost in that process. And so that's why we can't give you a definitive answer right now. But the answer is coming as we continue to move forward while vaccinating people at the same time.
Excellent. I appreciate that. I'll actually sort of chip in there as well, Dr. Moore, because a lot of times people ask that question and then they also ask about variants. And so I think it's important for people to understand, and this is sort of speaking to what Derek had mentioned before, you're going to see a lot of things online. And it's unfortunate to say, but 80% of the things that are online in newspapers are junk. They're junk media and they're clickbait. People are going to try to scare you about variants. Like Dr. Moore said, we don't know. But what we do know to date, as I put this slide up on the screen, is of the variants of concern that we have, whether it's the B117, the B1351, the P1, the B1526, 1429, and the India 1617. To date, all of them have been shown to have adequate neutralizing antibody levels in the lab. The UK, South America, and Brazil have actually been shown in randomized trials as well, some of the serum that they've pulled off, showing that they also have the antibody levels. And when we look at the real world evidence, which is truly where the rubber meets the road, in Israel, the United Kingdom, and Chile, as well as in Israel, because they have some of the Indian variant, they have consistently shown reduction in spread and transmission based on the fact that people have gotten vaccinated. And so I think, again, that's very important for people to understand where we're going with. We're in the last 10 minutes, and there's sort of two groups of questions that I'll throw open to the group. One of the questions, and I won't take it myself because I'm going to come back to Ms. Wilson because I'll answer that question in a bit. But there was a question both from Mr. Rains and Mr. Rice, which is essentially, how do we get back open? How do we get our offices open? How do we sort of get our lives back? And what is your opinion on the reopening of society based on the hospitalizations and deaths? I'll throw that open to anybody that wants to jump on it. We'll go from there.
Well, some of the things that will help us get reopened is reduced burden of disease, and vaccination has a lot to do with that as well because it prevents that burden of disease. Reduced hospitalization, for sure. And so these are really key things. These are really key things. There's also many indirect things that that contribute to that as well. So it's not throwing in the towel on the things that we know we need to do to keep ourselves safe. So I, you know, if I'm moving about in the hallways of my building, I'm still wearing a mask. I'm still wearing a mask in the train, even though right now I'm titrated up on my vaccine. I'm not going to throw the towel in on this tool. Social distancing, still going to be important. Being very careful about crowds, still going to be very important. So lots of things that we still need to do to pay attention to that. Now, I think one of the concerns that people may have is, and I mentioned this earlier, if we get to that point where we're able to open back up, what about the vaccine? Are we going to lose people's interest in the vaccine? It's really important that we all keep talking about how important that vaccine is no matter what. And you give the example of Israel, and one of the ways that we can impede on these variants is by getting vaccinated so that the development of those variants and the continued mutation of that is then dampened. So getting vaccinated is going to be critical on the way to reopening, and it's going to be critical after reopening. Because when we reopen, we will be opened up to many more people around us. So all the more reason to get vaccinated for ourselves, for the people that we love. And how about, you know, Derek was talking about servant leadership. How about for the people that we don't know and we will never meet, even in another country? We are all connected. We influence other people's well-being by doing the right thing and getting vaccinated.
Would anybody else like to chime in?
You know, I'll just throw this out there. There's other issues where the answers are more complicated and nuanced. You know, we have to tell folks that there's these 6 things you have to consider. We have to tell folks like there's this, you know, hierarchy of decisions and everything here. You know, if there is a silver lining in this pandemic, and I think the vaccines are that silver lining, let me just say this. The answer to almost every question on how we make life better, how we help people, is get vaccinated. Literally, it's the answer to everything. And it's one of those things where it's very simple, and sometimes we worry that it's too simple and that it's too direct. But if you want everything to open back up and you want life to return to normal, get vaccinated. Look at what's happening in Israel. Look at what's happening in the United Kingdom right now. Like, the progress is unbelievable, and I'm so thankful you showed that real world settings slide and that example, because the examples we're seeing of countries that really have gone all out on vaccinations is one of success. Like, life is starting to get back to normal. And that can be us. We're doing well. Don't get me wrong. The United States is doing very well compared to Europe and a bunch of other places. But when we look at the couple of countries that might be a little bit ahead of the US, they're really succeeding getting life back to normal. So if you're scared of the disease, get vaccinated. If you want to protect your friends and family, get vaccinated. If you want to talk about what Dr. Tokars was just talking about and help people you've never even met, get vaccinated. And you know what? If you're selfish and just want to go back to the movie theater or a ball game or whatever as soon as you can, get vaccinated. The answer to all of these questions is get vaccinated.
Absolutely. I love it. And I don't know if you guys can see my screen, but I pulled up the Financial Times COVID chart, and you can see there that even in Michigan, where we were most worried about what was going to happen in Michigan, and they had the leading percentage of B117, you can see how precipitously their cases are coming off as we've surged vaccine into that area. And whether it's Florida, Illinois, New York, Texas, California, they're all trending downwards or flat. And so what we're seeing is potentially cases going up a little bit in certain geographic locations as people get out and about a little bit more, but also the work of the vaccines to hold that flat. So we're now at the lowest level in the United States since October, which I think, like you said very aptly, Derek, if you have a question about COVID, the answer is always vaccines. And so as we sort of wrap this up, I'm going to double open up a question. There's a question about what can you say about vaccines in pregnancy and the potential long-term effect on kids. I'll go first and I'll throw it over to Dr. Moore. From a female standpoint, specifically women of childbearing age, women that are pregnant, I think all the organizations and medical associations that speak to that, for example, American College of Obstetricians and Gynecology, ACOG, have said very clearly that vaccines are safe and protective in women who are pregnant. I think the important thing to understand there is that it's a risk-benefit equation. What is the risk to you of getting a vaccine that's been shown to be safe versus what is the risk to you of getting COVID and being pregnant? And I know from personal experience, having had to see a woman that came in at 32 and 33 weeks pregnant, have an emergency cesarean section and die 48 hours later, that it's a painful event potentially when a woman who's pregnant, remember, women that are pregnant actually have a reduced immunity based on a host of other things, have that happen. I'll throw it over to Dr. Moore to sort of talk about the science of the vaccines in women who are pregnant, and then we'll try to wrap up with some positivity going forward.
All right. So really quickly, I won't belabor this point. You know, one of the CDC clearly recommends that pregnant women, of course, consult your physician and get the vaccine. The good thing is that after you get vaccinated and you start to generate antibodies, you can pass those antibodies in your breast milk on to your baby, so you can have some protection in that on that level. Probably the more interesting thing is that a lot of people don't know, and I think these are the as Derek has mentioned and as Dr. Alozie have mentioned, these are the things that are not put out. But during the Pfizer study, I think there were 23 women who actually got pregnant while on the study, while in the clinical trial. So if the vaccine had any effect on you not being able to get pregnant, those 23 women would probably not have succeeded. But of course, being in the clinical trial, they tell you to go live your life, do the normal things you normally do. And apparently they did. And 23 women got pregnant. So that just kind of speaks. These are facts that speak against some of those myths that are out there. And so we just have to speak truth to power and just keep moving and make sure people going in a positive direction.
I truly appreciate that. I'm going to sort of wrap up with a few more thoughts and then we'll kind of take it home from there. And so one of the things that I will say, and I promised I was going to end with good news, is that the data is accumulating and the CDC has pivoted to this point as well, that not only do the vaccines reduce your risk of getting sick, hospitalized, or dying, but they also have been shown to reduce asymptomatic transmission. And so if you can see on the screen, whether it's the healthcare workers study in England at 85%, the nursing home study in the United States at 100%, and you can see the references on the right, the first responders, or the largest study in Israel, that real world data showing 94%. These vaccines are amazing, and they also reduce transmission. I think when people say, well, what are the worst side effects that you can have? It's this: getting to hug people again, getting to touch people, getting to remove that mask and engage in society with that protection of vaccinated individuals working together. And so again, like Derek said, if your question is, well, what can I do? Get vaccinated. And 2 weeks after your last vaccine, engage with other people that are vaccinated. One of the questions that's out there is around, well, young people, 21%, 21 years old. I think it's important to remember that young people have consistently been the largest percentage of positive or COVID positive tests in the United States throughout this pandemic. What we've seen, however, is that those that bore the brunt of the death were above 65. We've on average protected them to really reduce the spread and get us into the next phase of potentially opening our country up freely. We're going to need those youths to get vaccinated. And so whether it's to protect themselves, to protect their parents, to protect other people, to go back to school, where some of those mandates are going to come from universities going back into the fall, I think vaccines allow us to get back to normal. In closing, I think nothing should necessarily go back to normal. Normal perhaps wasn't working. If we go back to the way things were, we would have lost the lesson. I think we need to do better. think we need to rise up. And people often say, man, but this is so difficult. Yeah, the simple stuff is easy. Who says that we can't do the complex with the right thing, which is get those vaccines out there, get our community protected, and get back to normal. I'd like to thank all of the people that were involved in this today, whether it was Dr. Ian Moore, Dr. Lamar Tokars, Derek Lindblom. I really want to thank you for an exciting and engaging panel. And I'll throw it back to the group and see where we go from there. But God bless everybody and stay safe.
Absolutely.
Thank you, all the speakers. What a dynamic session with so much great information. We're hoping to continue to share this information to get this message out so that we can get those folks who are, the maybes, to get those maybes to vaccinate, to get those people who are the hard nose into being maybes and starting to work on them. What great information. And just want to just thank you so much. I was very excited to see all the questions coming through the comments. A lot of things that we've all heard before that you guys were able to shed a significant amount of clarity on. So I think that's fantastic. And I also wanted to take the additional liberty of saying, now that we've connected and established this relationship, don't be surprised when we call on you again. And so, so thank you so much. And just in closing, I just wanted to thank everyone who's participated in this 50th anniversary conference over the last 2 days. It's been a great kickoff to Community Action Month. And I want to thank our boards, IACAA board, ICAC board, for your guidance in the development of this conference agenda. Thanking our staff, particularly a special mention to Haley, our conference organizer, for making this a smooth virtual conference experience. And also want to give a special shout out to somebody who's not here. My son, Noah Dawson, actually came into the office on his birthday to pack the conference bags for our early registrants, and just wanted to thank him as well.
Good job, Noah.
The theme for the items that are in those bags are following sustainability, and so they're to try to reduce the usage of disposable items. Things like the bag is a insulated grocery bag with stainless steel water bottle, reusable eating utensils, stainless steel straw, hot and cold pack that could be used for aches and pains, and also just to kind of wrap things up in a very final note, is while the conference has come to an end, our celebration is not over. We're exploring the idea of an in-person event this fall in anticipation of hopefully reaching that herd immunity that we've heard talked about. If we can get there, and let's take the message that Dr. Alozi, Mr. Lindblom, Dr. Moore, and Dr. Tilkars gave us to heart, and ramp up our efforts to increase understanding and ease access to vaccines. We all need to do our part to protect each other. And please remember to complete the session and conference evaluations, because we do use that feedback when planning our next events. And we wish you all the best. Thank you for participating today, and please take care.
Stay safe, everybody. God bless.
Thank you.
Bless.